Hi, good evening, everyone. Welcome to the BGCS webinar group. Sorry for a slight delay. We've had a few tech issues as always. So really happy to host a webinar tonight on the National Ovarian Cancer Audit, and thank you so much for the team that have come to speak. Just a little bit of housekeeping before I let them start. So anyone that's attending today, would be really grateful if you could complete some feedback, because most importantly, if you complete feedback, then you will get a certificate of attendance, and that will come within the week. If you know anyone that can't log on today to listen to this fascinating talk, then it will be available on the BGCS webinar group, and that's for anyone that's a BGCS member, so they can catch it there. And lastly, if you do have any questions, which I'm sure there'll be plenty, if you can put them in the question box rather than the chat box, we'll go through those at the end, and hopefully we'll have plenty of time for questions. So I am going to hand over to the group now to introduce themselves and talk a little bit more about the background. Sudha should hopefully be joining as well if we overcome our tech issues. So I'm going to hand over to the team, and thank you again so much for talking.
Great. Thank you very much, and welcome everybody. So if we start from introducing the team, so my name is Agi Oranushka Michael. I'm a medical oncologist and one of the clinical leads for National Ovarian Cancer Audit. I sort of look after the side of chemotherapy, and Sudha, who I'm sure you all know and will join us shortly, is the clinical lead for surgical side of chemotherapy. And if I pass on to my colleagues to introduce themselves. Andrew?
Yep, so I'm Andrew Hutchings. I'm a methodologist on the audit, and I'm based in the Clinical Effectiveness Unit at the Royal College of Surgeons and also at the London School of Hygiene and Tropical Medicine. Georgia?
Hello, everybody. My name is National Ovarian Cancer Audit. Ipek?
Hello, my name is Ipek Organja, and I am I'm the methodologist for the audit, and I'm similar with Andrew. I'm based at the London School of Hygiene and Tropical Medicine.
Fantastic. So, Georgia, do you want to start with an introduction?
Yeah, so we're still waiting for Sudha, but I'm happy to give a short introduction about our team. So, as we said, the National Ovarian Cancer Audit team has two clinical leads, and Professor Sudha Sundar is the clinical lead for surgery, and Professor Agnieszka Michael, she's the clinical lead for oncology. And our team also has some London School of Hygiene and Tropical Medicine academics, and these are Professor Jan van der Molen, Dr. Ipek Gurul-Urganci, Andrew Hutchings, Joe Budur, who is the project manager, and myself as the clinical fellow. So starting off with some background to the National Ovarian Cancer Audit. So the National Ovarian Cancer Audit has commissioned after the Ovarian Cancer Audit Feasibility Pilot Project, which was announced in 2019, and it was a jointly funded project of the British Gynecological Cancer Society, and the Ovarian Cancer, Action, and the Target Ovarian Cancer Charities, as well as the National Cancer Registration and Analysis Service. So they used routinely collected data in England. The first report came out in January 2020, and to date there are 5 reports published. So some key findings from the feasibility pilot are that the incidence and diagnosis, so in terms of the incidence, that was broadly stable over time, with variation in incidence and stage of diagnosis. Sorry, I'm trying to move I'm really sorry for that. Between the cancer alliances. In terms of treatment, they've showed that treatment was less likely in patients diagnosed with stage 4 and for surgery for patients over the age of 79. And there was variation between cancer alliances in the rates of treatment. In terms of survival, that was improving over time, but again, there was substantial variation between cancer alliances in 1 and 5 year survival. And there was less variation in the 2-month survival. So there was some lessons to be learned from the feasibility pilot. One of them is that the surgical radicality score can be obtained from routinely collected data, but that requires some validation. And there were several issues regarding data completeness. For example, figure staging, the performance status, as well as recording of residual disease. And that brought us to the National Audit Collaborating Centre, known as NATCAN, which is based at the Royal College of Surgeons of England, and that was commissioned by the Healthcare Quality Improvement Partnership to deliver NATCAN. So it was funded by the NHS England and the Welsh Government. NATCAN has 10 audits. So there were 5 pre-existing audits, and these are the bowel, esophagogastric, prostate, lung, and breast primary. But also there were 5 new audits which joined NATCAN, and these are the pancreatic, kidney, ovarian, non-Hodgkin lymphoma, as well as breast metastatic cancer. And as an audit, we do have some reporting requirements. So there is a requirement for an annual State of the Nation report. So this report is for NHS organisations within England and Wales and will highlight where services should focus quality improvement initiatives. The annual State of the Nation report will be using gold standard cancer registration data, and we will explain later on what these data are. But also, we are going to have a quarterly dashboard indicator. So there will be regular updates containing NHS organizational level results, and there will be indicators which will facilitate benchmarking and monitoring of performance. So improvements in performance can be tracked over time. And this is focused on timeliness of reporting by using the rapid registration data. So moving on to the improvement goals, another requirement from the HQIP was that each audit will have 5 improvement goals. And as the National Ovarian Cancer Audit, we decided to develop improvement goals for the whole care pathway, which include diagnosis, treatment, as well as clinical outcomes. So the first goal is about increasing the proportion of patients receiving timely diagnosis and treatment decisions. The second goal is about increasing the proportion of patients receiving molecular diagnostics. The third and the fourth goal are about treatment. So the third goal is about increasing the proportion of patients receiving surgery. And the fourth goal is about increasing the proportion of patients receiving chemotherapy. And last but not least, the fifth goal is about improving rates of survival and reduce variation in survival, which is about clinical outcomes. So these healthcare improvement goals are feeding into some performance indicators. So we've developed different indicators that can be mapped to these improvement goals. And these indicators that we have developed are very closely aligned to the BGCS quality performance indicators for ovarian cancer that the BGCS has recommended. So for the first improvement goal, which is about increasing the proportion of patients receiving timely diagnosis and treatment decisions, the indicator that we're going to measure is the proportion of patients with ovarian cancer who were diagnosed.
Welcome to the webinar. You have entered as an attendee in listen-only mode.
And this is very important because, as the ovarian cancer feasibility pilot has shown, women presented via emergency were 4 times more likely to die within 2 months from diagnosis compared to women who were referred by the 2-week wait pathway. For the second improvement goal, which is about increasing the proportion of patients receiving molecular diagnostics, we have developed 2 different indicators. So the first indicator is about the proportion of patients with epithelial ovarian cancer on histology receiving germline panel testing. And the second one is the proportion of patients with advanced stage, and that's stage 3 or 4 or unstaged, high-grade epithelial ovarian cancer on histology receiving HRD testing. And moving on to the treatment improvement goals, to kind of increase the proportion of patients receiving surgery, we're going to calculate the proportion of patients with stage 2 to 4 or unstaged ovarian cancer who receive cytoreductive surgery. And this indicator also derives from the findings of the Ovarian Cancer Audit feasibility pilot, which showed that 51% of the patients actually had cytoreductive surgery if they had stage 2 to 4 or unstaged ovarian cancer. The fourth improvement goal, which is about chemotherapy, for that goal, we're going to measure the proportion of patients with high-grade epithelial, stage 2 or above or unstaged ovarian cancer who receive platinum-based chemotherapy. There is also another performance indicator which kind of sits between the third and the fourth improvement goal. And it's about the proportion of patients with stage 2 to 4 or unstaged ovarian cancer who receive any type of treatment, which can be surgery and or chemotherapy. And that's really important because the feasibility pilot has shown that only 20%, that 20% of patients actually did not have any type of treatment. And the fifth improvement goal, which is about improving rates of survival and reducing variation in survival, is having its own indicator, which is the proportion of patients with ovarian cancer who are alive 1 year after the diagnosis. So just to sum up everything, we have these 7 performance indicators that fit in the 5 healthcare improvement goals, and this formulate a healthcare improvement plan. So our first healthcare improvement plan will be published at the end of April and will be updated yearly with new recommendations. So I'm going to hand over to Andrew now, who's going to talk about data and audit reporting. Over to you, Andrew.
Yeah. Now that Suda's managed to get a working microphone, I don't know if there's anything you want to add at this stage, Suda.
I hope you can hear me.
Yes, we can.
Yes, thank you. So no, I will. I'm quite happy to take questions at the end, and we can carry on. Thank you, folks.
Okay, I'll just ask the next slide when I'm ready, Georgia. So I'm going to talk about the data that we're using and how that's going to feed into the various reports that we'll be producing. So one feature of all of the NatCan audits, including the ovarian cancer audit, is that they will only use routinely collected data in England and Wales. So we won't be getting any data directly from trusts, and we won't be doing any bespoke data collection from trusts either. In terms of our timetable for reporting, then we've just published our first quarterly report on data completeness, and we'll be doing further development work for a second report also on data completeness in July. The first State of the Nation report, the annual report, is going to be published in September, and then October will be when we publish the first quarterly report on performance indicators. Next slide, please, Georgia. So in terms of the data we're using, then it's not entirely fixed, but for the quarterly reporting, we will largely be using rapid cancer registration data provided by the National Disease Registration Service, NDRS, and that's going to be our most up-to-date data. So, for example, we received data in February 24 that included patients diagnosed in the rapid cancer registration data up to the end of October 2023. So there's about a 5-month lag between when diagnoses are made and when we would be receiving data. We will get these data on a quarterly basis, which is why we'll predominantly be using these to feed into quarterly reporting. Those data are also linked to other key data that's collected routinely, and perhaps the two most important ones are the hospital episode statistics. So that would include more detailed information on surgery, for example, and the equivalent for Wales, which would be the PEDU patient episode data. And in terms of anti-cancer agents, chemotherapy, then that will be coming from the SACT data set. We'll also be getting, go back please, Georgia, we'll also be getting annual data for both England and Wales. For England, this is what we refer to as the gold standard cancer registration data, and this data is the final process data provided by NDRS, and that's why there's a longer lag in these data, but they will be far more complete and provide the highest quality data that we'll be receiving. And for example, if we've received data in January 24, but that's for patients diagnosed up to the end of December 21. The equivalent data we'll be receiving for Wales is actually slightly more recent. So for example, we received the Wales Cancer Registry data in February this year, but that includes patients diagnosed up to the end of 2022. And again, those data sets will be linked to other national routinely collected data. There would, of course, be some differences between the data collected in England and collected in Wales. So that's something that the audit's going to be trying to align as much as possible for the work that we'll be doing. Next slide, please. One of the things we've been working on, thinking about, very much in development, is the levels we're reporting at. And an ambition of the audit is to be able to report some of our indicators at a cancer system level, rather than, for example, at a trust level or a cancer alliance level. And we're keen to do this to reflect the organisation of gynecological cancer services in a hub and spoke or a centre and unit model, with units often referring patients on to centres for some of the surgery, for example. And we would see this in England as sitting between reporting level at the NHS Trust and a reporting level at a larger grouping of the cancer alliances. So I think we would end up with, I think, 41 or 42 of these hub and spoke systems in England. This is also possible in Wales as well, where this would act as a level between the hospitals or the health boards in Wales and a national level, and it would match with the 3 cancer centres operating in Wales. So some of the advantages we'd see is that this would be very much about how services and decisions are organised, and perhaps maps better with MDTs. There are some challenges as well. So certainly there's some NHS trusts which have sort of legacy mergers where there are different referral systems, perhaps to more than one cancer centre, and that's where we'll be getting in touch with you to find out, well, how is it best if we want to work with this level of reporting to allocate patients between different cancer systems. So I'd be very keen to hear from you, and please put any comments in the chat function. Next slide, please, Georgia. So in terms of our first report, this is on data completeness, data quality indicators. We're a long way from reporting on the actual performance indicators, and this is very much work in progress. So again, we're keen to hear from you and as we develop this piece of work. So the report was published on April the 11th last week. It's only based on rapid registration data for England, and we've taken quite a broad approach to inclusion at this stage. That's something which, as we do more development work, we will be able to develop tighter criteria for determining who is included in our reporting. We focused on 6 indicators covering the basis of diagnosis, the route to diagnosis, which will be important for an indicator relating to emergency presentations, completeness of staging, performance status, morphology in the patients who have a diagnosis based on histology, and also recording ethnicity through routine data. We've reported this by grouping the data in a 12-month period up to patients diagnosed for 12 months to the end of September 2023, and it's reported at Trust, Cancer Alliance and national level. We've had to put it at a 12-month level because of the number of trusts we're reporting on, 124. And if we were to reduce it to say 6 months or 3 months, then we would end up with some very small numbers. As it is, we are reporting data on trusts with between 10 and 140 women diagnosed and captured in the rapid registration data over that 12-month period. We're also reporting those data quality indicators both cross-sectionally to allow trusts to compare themselves alongside other trusts, but also longitudinally so trusts can see how completeness of a particular data item has changed over time. We've also included some information on patient characteristics. Next slide, please. Before I actually show you the dashboard, there are some very important caveats to take account of in trying to interpret this. So this is work that is being developed, and we will be making amendments based on feedback and further development work with the data. So the dashboard uses rapid cancer registration data. So this is the semi-processed rather than the gold standard registration data, which would perhaps provide the most valid but not the most timely data for reporting. What you see in the dashboard is unlikely to reflect much of the local data available to you, because what you're seeing is the data that's available to us for the audit. So the flows of data are based on what you trusts will be submitting, for example, as part of your COSD submissions, or what gets submitted from the pathology laboratories that then gets submitted to NDRS, and they will then process that and turn it into the rapid cancer registration data set. So that means that what information locally you may have, for example, on data on staging of all your patients. If, for example, there are delays or it hasn't been fully processed in terms of the rapid cancer registration data, then we won't be seeing that in the data that we actually receive for reporting on the audit. So this means that perhaps locally you won't find a very good match between what's presented in the dashboard and what is what's available to you from your own local systems. Where we would expect a closer relationship is between the data on the dashboard and the data for your trust that is presented on Cancer Stats 2. It won't be a perfect, and we expect there to be differences as well. One of those reasons is that the dashboard currently includes patients diagnosed with peritoneal cancers and also cancers of uncertain or unknown behaviour of the ovary. So those are currently included, and we have some development work to do to try and ascertain how many of those are not actually gynecological cancers, how many end up perhaps being an ovarian cancer diagnosis. In the case of the uncertain cancers, we would want to know, well, how many of those are confirmed perhaps as borderline tumours, and how many might actually subsequently be confirmed as a C56 ovarian cancer diagnosis.
So Andrew, I think just to add to that, I think this is the starting point and it's an iterative process, but we would still be really appreciative if you could please check the data that is being entered into COSD locally and then link in with your local NDRS data improvement lead, and the data is there in public domain on the spreadsheet that's been uploaded, because whilst we are getting a fraction of the data, it still will be really helpful at your end, because this is an iterative process. It will get better and the next iteration will be better than this iteration. So it's a two-step. We both have to, the trusts, our partners as well as us, have to work together to try and get data completion as high as possible. And I think our plans are for the next dashboard to present two views, isn't it? The view with just, I don't know if that was your next slide, without C48 and D39 and with C48 and D39. So then hopefully at the next iteration, we'll end up with data that is more truly reflective. But even at this stage, it would be really helpful to check data flows.
Yeah, certainly do get in contact with your local NDRS data improvement leads, and there is information on the NatCan website of who they are as well, if you need to find them. So it is going to be about trying to improve the quality and the completeness of the data. It's going to be an ongoing process, and it will be a mix of us working in the audit, the trusts, and also NDRS to try and improve those flows of data, the timeliness of data, and ensure that what we're feeding back to you is making sense to you. So next slide, please, Georgia. Oh, I think I'm, yeah, sorry, I need to switch to the dashboard now. So I need to be smoothly transferred, and then I should be able to open up the my copy of the dashboard. If I can find where it's gone again. Right.
In the meantime, if anyone had any questions, please type them, and we can start answering them whilst the PowerPoint. We're on.
Okay, so I've managed to show my screen. So this is the first sheet of the dashboard that shows the cross-sectional data completeness. So if you haven't seen this already, then what it shows is an ability to look down here. Hopefully you can see the screen changing as I move my cursor around. So you should be able to select whichever trust you want to look at. Unfortunately, Airedale will always end up, whilst alphabetically it's first on the list. So apologies, Airedale, if you are consistently being picked on by us when it comes to showing a lot of these things. You're also able to select which of the indicators you want to look at. So currently we're looking at the completeness of the basis of diagnosis, whether that's been recorded in the rapid registration data or not. In this case, Airedale has over 95% of diagnosed patients with a recorded basis of diagnosis. It also shows here the cancer alliance that it belongs to, which again similarly performs around the 95–96% level. And also you can see nationally what the figure is as well. So nationally, of patients diagnosed, 85% have basis of diagnosis completed. Down here, there's a list of the 6 trusts that make up the West Yorkshire Cancer Alliance. So it's possible to have a look at each trust alongside the other trusts within the same Cancer Alliance. On the right, then we have a bar chart showing where Airedale appears in terms of ranking across all the NHS trusts in England. And there's an arbitrary 90% threshold which has been applied to all the NatCan audits at this stage. But then that's been applied across all the indicators rather than it being set specifically for any individual indicator. So if you wanted to change to one of the other ones, if you wanted to look to how complete route to diagnosis is, then again, we would see Airedale recording 100% of patients. It says number 1. We've actually got quite a few trusts tied at number 1. But every trust that's 100% would be scored at a number 1 rank. So that's the cross-sectional analysis that also allows reporting at Cancer Alliance level and national level as well. The second way of looking at the data is longitudinally. So again, we've got the data for Airedale, and we're looking at basis of diagnosis, and along this top line here shows how complete the basis of diagnosis is on a rolling 12-month chart. So each of these points here represents 12 months of data, but we're just moving it along 3 months every time. So it's a moving average that we're recording here, and again you can see there's very little change along the top. If we switched to another indicator, for example, looking at completeness of morphology, then we see that it is complete, but perhaps there's a little bit of a tail off with the very recent data. That's likely to be the most recent data that we're reporting for not being fully complete in terms of the data coming through to the Rapid Cancer Registration System. The final area where we're reporting on is on patient characteristics, and this is where we do have to apply suppression to the data to deal with small numbers. So we're not in a position to present very small numbers, and we've used a threshold of 25 below which we wouldn't report a trust. In this case, Airedale falls below the threshold, and in this column then it doesn't include any data. We do include data at the Cancer Alliance level, and we also include it at the national level. If we were to switch trust, then we would be able to have a look. If we look at Barking, Then, sorry, we're still on Airedale here, but if we switch the trusts here to Barking, then we would see that there are enough patients diagnosed over that 12-month period to report some characteristics, but on others, we still need to suppress the data. So again, this might be something where reporting at a higher level, perhaps a cancer system level, would mean that there would be less suppressed information in doing this. There's also information describing the audit and the dashboard, and some of those caveats and explanations are also included in the explanations tab. So I'm going to leave it there. Hopefully you've got plenty of questions. Please post those in the chat, and I will try and stop sharing my screen and hand over to IPEC. Has that gone back to everyone?
Georgia, are you sharing the presentation, please? Thank you.
Yeah, give me 1 second. How do I become the presenter again?
I may need, oh no, it's been done.
Okay, yeah.
I've done it.
Can you see my screen?
Yes, thank you.
Okay.
Thank you very much. The previous one, please, Georgia. Thank you.
Yes.
So I'll be following up with our future plans, actually 2024 plans for reporting, and we've already discussed this to some extent. So our next report will be another data quality report. It's a quarterly report based on data completeness, and it will be actually following a very similar approach as has been published last week. Having said that, we do recognize the caveats, and that we were receiving feedback, very important feedback from you. So, for example, you'll be making a number of changes given the feedback, as Sudha mentioned. For example, having two indicators for staging, one of them having a broader definition of broad denominator, and then one that's actually excluding patients with the 2 ICD codes that the NDRS does not report staging on. In addition, there are a few additional data quality indicators that we would like to plan for including, and that's really based on comparing the rapid registration data with the gold standard registration data, and we really understand the limitations of the rapid registration data, and how, in terms of the changes of trust of diagnosis and difference of morphology, and how the two data sets compare in terms of the completeness. And as Andrew discussed, this might also be our first opportunity to report at a cancer system level rather than the Trust, Cancer Alliance, and levels that we've discussed before. Next slide, please. So after the second quarterly report, our first report will be the State of the Nation report, and this will be the first report on the performance indicators rather than data quality. So the State of the Nation reports are quite relatively brief reports at the national level, looking at performance indicators, as well as providing information on data completeness, also patient characteristics. And the report is actually will also have recommendations based on the key findings on the report. At the same time of the publication of the State of the Nation report, we will have comparative dashboards similar to what you've seen, and that will be aimed to again produce at the cancer system level. And then there's further information. There'll be further information of the methods and definitions and risk adjustment, and any other limitations that are in the data and the methods as well. But the State of the Nation report will primarily be based on gold standard data. And then the first quarterly report that's based on performance indicators, we expect to be published in October 2024. And so that, again, will be based on the rapid cancer registry data. And so currently we're doing development work and testing of the proposed indicators to look at essentially which performance indicators can be reported in the State of the Nation using gold standard data, which performance indicators are suitable for including in the quarterly reporting, but also identifying what are the further development needs for some of the indicators and what are the other testing and methodology needs before they're actually suitable for reporting. For some of the indicators, for example, we currently do not have data that we expect them to be coming in upcoming reports, but not in 2024. And I'll now hand over to Aggie to talk about our future plans and missions.
Thank you. So going forward, we've got a number of goals and sort of data items that are still in development. So as you could see, for example, regarding chemotherapy, the first reporting will be just focused on the number of patients receiving platinum-based chemotherapy. But what we would like to do in the future is to be able to report how many patients get the optimum treatment, as in the combination treatment, how many patients are given just single agent, whether it is limited to older patients or whether that varies depending from the trust. We also want to look at the maintenance therapy, how many patients receive PARP inhibitors, how many receive bevacizumab, how many receive the combination, and how that compares to their sort of HRD and BRCA reporting. We might be able to look at other items such as chemotherapy timing, for example. There are obviously surgical goals in development, and I'm sure Sudha will want to add to that, but we want to look at the residual disease and the quality of the surgery, which again, it's a development process. We wanted to do some research projects. So we have obviously Georgia, who's our research fellow, and we also have another research fellow who has recently started, who will be able to look at electronic frailty assessments in the context of chemotherapy and chemotherapy toxicity. And in the broader term, what we really want to do, obviously, is to learn from the audit and look at for what we call them positive deviants. I know it doesn't sound very nice, but essentially trusts that perform better than others. What can we learn from them, and look at a little bit more granular data and the practice that we could share amongst other trusts, and also identify further indicators that require development. So as you can see, it's a long-term project. It will take a long time to get to those sort of more developmental plans and ambitions, but I think it's very exciting, and I'm sure you will be interested to hear about it again in the future. So can I have the next slide, please? Which is actually thank you, and are there any questions? I don't know if Sudha wants to add anything to our future plans.
It's a thank you, and I apologize for joining a bit later and having technology issues. I forgot the GoTo platform actually. I thought I had a memory of Zoom or something that was much easier, but GoTo has always been slightly problematic. So to say this is a different iteration to the ovarian cancer feasibility pilot, where there was gold standard data, and obviously that's the best quality data we can get from the national data sets. But the disadvantage is it looks back a few years, and so you don't understand what current practice is, and you can't actually pick up change in practice really quickly because you're looking back those many years. We're hoping, although this is data that we have to learn and we have to work with you to get it to the best place possible, that actually we can look more contemporaneously. So we can look back just in 6 months the data is available. So you can look back at 2022, 23, in early 2024, which is just, that's correct, isn't it? We can look at 22, 23 in early 2024, which is just simply amazing because that's just a 6-month time lag. But we're still working on things. We're still trying to get our head around the differences between the gold standard data and the rapid cancer registration data. So please feed back to us. This is an iterative process. We will be very responsive to things that look different at your end and look different at our end, and we can unpick it. And before we start making really decisive statements about the state of play, there will be this sort of iterative process of trying to get the data right, trying to get the data flows right, trying to get the service mapping right. So there's lots of opportunity to feedback. We're all very accessible. Georgia is incredibly accessible, so please bother Georgia, and we will be responsive, and we will try and we will certainly look at the data to make sure that that's correct, and we will try and explain it where possible. We will caveat the data where possible. So this is going to be a very different process to the previous feasibility pilot, which I was very privileged to be part of, and was extremely high quality. But we need to build on that to try and see a more contemporaneous set of data, and also a data that shows how change is happening and how change can happen. So I think there's huge opportunity and potential for us to look at the data more carefully. I think to rebut some of the statements about quality, to try and have data in public domain that is useful for patients and for clinicians in terms of what the outcomes by cancer center unit are, and it allows us, I think, then to put in measures that improve care. And there's a real emphasis on positive outliers, so people who appear to be performing better, and that needs unpicking, as Jan would say, that it's really important to make sure that that's a real effect rather than a spurious effect. But nevertheless, I think there's an opportunity to kind of all move forward with this effort, and that's really what we're trying, I think. So we look forward. I'm surprised that we have no questions and 60 attendees, so either we're not seeing.
We do. I can talk you through them, so there's plenty. So thank you so much. Excellent talk, really, really promising work, and I'm sure we all wait with bated breath. So Elaine has asked, and I think Aggie, you touched on this, so about the plans to compare the type and the amount of adjuvant and neoadjuvant chemotherapy given, and they've commented there's a big variation in the practice that they see. Could you just talk through maybe in a bit more detail what you plan to do, what you're hoping to look at?
So yes, I mean, the plan is to look at that as well. Again, it's something that we need to develop and look in more granular way because of the timing. The way you know we record the chemotherapy is the timing to start from the surgery, how long it takes for the patients to go from the surgery to start chemotherapy, because that's something that we really don't know, and also whether we'll be able to look at the numbers of patients having neoadjuvant chemotherapy and then adjuvant chemotherapy. Again, it will be a question of looking at the dates and the time intervals in order to establish, whether it is because essentially what we'll be doing at is looking at the gaps between the chemotherapy cycles to know whether there was, whether the surgery is in the middle or at the beginning of the treatment. So that will be a little bit tricky, I think, but I'm sure it's all doable, and that's something we'll be looking at.
So there's a practicality question here. So to whom should we address information regarding local regional variation referral patterns? So it's something that you touched on.
So Andrew's done an amazing piece of work. Andrew and Georgia have done an amazing piece of work looking at service mapping. So we can actually look at the data flows, at patient pathways directly from the data itself. So so there's quite a lot of clarity at the moment. Where we are unclear, the plan was to reach out to the BGCS and ask for contact information. But if people feel that they need to give the data flows because they know what's going on locally, then Georgia, are you happy to be contacted?
We have a generic email account, which is on the bottom of the slides. It's on the website. So please contact us on there, and then that's monitored and can be sent to whoever it is the appropriate person to try and respond to it.
And it means that annual leave is covered and that sort of thing. Yeah.
Fabulous. And there's a question that they want to get on the data. Please could you share the link as to how to look at the data? Where is that available?
So the dashboard is available on the NatCan website. So just stick NatCan Knocker into your preferred search engine, and that should take you straight to the Royal College of Surgeons NatCan website. Go to the Knocker page, and then under reports, click there. We have had some issues with people not immediately being able to change, for example, the drop-down trust list. So if you are using it, the best thing is to download the dashboard onto your own PC device, and make sure that you enable editing in order to be able to use that functionality.
And presumably then if you download once, that's the current version, and you would have to re-download as the dashboard updates?
Yes, there will be a new dashboard in July for the second report, and that would be a separate link on the Knocker webpage.
So there's also a question about genetic testing, which I think was mentioned, and how do you plan to capture germline testing, tumour testing, because it could get slightly complicated. How's that going to be unpicked?
That's still being unpicked. So we have lots of deep and meaningful conversations with NDRS about the data. And where the germline data will be, and where the tumor data will be, and how we can integrate it. And so that is an ongoing conversation. I think it's fair to say we're not as far forward as we would like to be, but this is being worked on actively. So it's a very political response, but basically we're working on it.
Okay, so we'll wait to hear.
Yeah, exactly.
Okay, and Joe Morrison has said, will the data update, so if we go back into SCR, which I guess is Somerset Cancer Record, and we clean our data to try and help you guys out, will that improve the quality of the data that you can see?
So it will do to a point, in the sense that right now it won't do anything to this version, obviously, but it will do it for the next iteration and the next iteration afterwards, because it just moves forward 3 months. That's correct, isn't it? It moves forward 3 months. So yes. So it will be 6 months and then 12 months. So it will keep moving forward 3 months. Does that make sense? Somebody needs to explain this a little bit better than I have at the moment. So basically we get data from 2022 to 2023, and then the next time we look at the data, we'll get it 3 months after the date that we looked at it. So if you can go back and clean up the data, it will make a difference, not to the data that's on the dashboard right now, but to the next time the data comes on.
Perfect. And I suppose my question is that I don't know when for example, COSD data is collected. Is there a data validation process during that collection process, or is it required further down the line? Will there be a validation process with the data that you're getting in a small cohort?
Andrew, are you okay to take this?
But there's the link between the trusts and NDRS, who have the primary responsibility for processing and checking all the COSD submissions. We do receive some of the COSD data alongside the rapid registration data, but we don't have any direct role with the trusts in COSD. That's very much for NDRS and the trusts to look at ways of improving those data flows.
Okay, so when you get the rapid diagnosis data, it's all been validated and cleaned, and that's how it comes to you.
But there's the validation that NDRS will do as part of their processing, both of the rapid registration data and the full gold standard registration data. We will be doing some of our own checks to make sure as well that what we're reporting, so it'll be a two-stage process. NDRS will do what they do, and in the audit we will also be doing our own checks as well. But we won't be reporting, we won't be going back to trusts saying your COSD submission was late. We won't know that level of information, but what we will know is if the COSD data hasn't been translated into, for example, a recording of a stage at diagnosis, because we'll see that in our the rapid registration data, and that's something that between us we would like to improve as far as we can. Both the timeliness and the accuracy of that.
What would be massively helpful for us, particularly for going forward for surgical data, is if people went back 1 year or 18 months and looked at, and for that 18 months looked at their staging information and for their residual disease information. That would be most helpful, most gratefully received, and it will start showing up from the next iteration onwards. It will update it. So it would just
that's your
sorry,
plea for everyone.
That's our ardent plea. It's only 18 months behind, so we are, say, from March 2024, 18 months count back. If you looked at it and you did that piece of work, that's not a lot of cancers for any MDT administrator. If they could please go and look to see whether their staging data is complete, whether it's in the right place, because often people don't, there's some confusion about who, so this is why you need to liaise with your NDRS data liaison person to ensure that you're putting the data in COSD or Somerset in the right place, and the residual disease data and the performance status data. This would be massively helpful. And essentially performance status underpins everything in surgery and chemotherapy. So we really need that data.
Perfect. So that's noted. I'll take that back to my trust tomorrow. So that draws the end to the questions. So it's absolute perfect timing. Thank you again to all of our speakers. It's been really fascinating. Can't wait to hear what's going to come up. Everyone in the audience, please do fill in your feedback questionnaires. It'd be really gratefully received, and also you can get your certificate. So unless there's any more last minute questions coming through, I will draw things to a close and say thank you very much to our speakers.
Thank you for the opportunity to present, and we're very keen to come back and present when we have more data. Just so
I'll be in touch.
Thank you.
Okay. Good night.
Bye.